All right, it is now 6:05. We're going to get started. Welcome, everyone. Thank you all for coming to the Local Mental Health Board meeting on September 4th in Woodland, California. We are going to start off with public comment, and we have some guests here, and I'd asked them to introduce themselves and tell us their interest in being here. So they have to kind of speak a little loudly, right?
No, it should capture.
Okay, 'cause
Yeah.
there's like 400 people on Zoom watching.
That's not true.
Don't freak them
They're
out.
no fun.
100 people.
I just told them it was 5.
It'd be shocking if there was.
But hi, my name is Violetta. This is Allison.
Hi, it's nice to meet you.
We're from World Relief, so we're a refugee resettlement agency. We're based out of Sacramento, and most of our clients that we serve move to and resettle into the Sacramento area. But we have just recently found out from the Department of State that our numbers are increasing significantly, and we'll be moving out into surrounding counties such as Yolo. So we're really out here trying to find out what mental health services exist, what federally qualified health clinics exist, try to just make friends and partnerships and really just find out about the resources that we can start referring our future clients to. So we're trying to be proactive and ahead of the game before we see high numbers of arrivals. So thanks so much for letting us join today.
Thank you for coming. We appreciate it. Okay, any other public comment from people that are on, our 400 people that are on Zoom? Okay, all right.
Not one of them has something to say.
Out of 400. Okay, approval of the agenda. Can I get a motion to approve the agenda?
So moved.
Chris, thank you. Second from Sue. All in favor?
Aye.
Opposed? Any abstentions? None? Okay, we'll move on to the minutes. Can I get a motion to approve the minutes?
Motion to approve.
Motion to approve, okay, and second?
Second.
Got a second? Got that? Okay. All in favor, say aye.
Aye.
Opposed? Abstentions? Okay. All right, member announcements. Any member announcements?
Just a reminder, we have the NAMI Walk September 28th at Woodland Community College. I know our diversion criminal courts team is going to be there, hopefully en masse. Encourage everyone else to participate. Last year, Brad got an award. It was a good event.
Yeah, and you can join the collaborative court team, right? Chris can give you the link, or Terry.
I would Google NAMI Walks YOLO, and there's a link.
Yeah, right, NAMI Walks YOLO, you can see the collaborative court link. All the donations go to YOLO NAMI. So we used to do the walk in Sacramento, but all or most of the money went to Sacramento. So now I think some of us still walk in Sacramento, but we have our own walk in YOLO to keep the money.
Last year
local.
was the first one in
Last
YOLO.
year was first. Okay. So, okay. Any other member announcements? Okay, chair report. I have nothing to report. Correspondence.
We received correspondence, it's included in your packet, and it was the notification of the changes to the requirements for the board if someone has a disability.
Oh, right, so there's a new, was that I can't remember if that was an opinion or if that was legislation, but the requirements for the Brown Act have changed with respect to people with disabilities. That could obviously impact any board, this one also. And I have asked county council to give us some advice, which he was already working on. They're already working on that. So they're working on a little memo on how to apply the law and how it will work in the future. So more to come on that. But that'll allow, I think one of the big things is normally when you're on the board, if you're off site, you have to publicize your address. and you will not have to do that anymore. That's one of the pieces of it, but there's probably more to it. Anyway, we'll hear from Phil in the future. Okay, item 7. So I put Dr. D, right, and high up on the agenda. Do you want to come up here? And so I feel like saying, ta-da! You've probably never heard that, right? Never heard that. Never heard that. We're really pleased to have Dr. D here with us. You could have a seat. You could have a seat in any of these seats if you want, or stand if you'd like to stand. And Dr. Dutta was not really prepared he didn't prepare anything, but I just asked him if he didn't mind telling us, his background, where he came from, what he's seen, with the county so far, and what he sees for the future. So thank you for joining us. We really appreciate it.
Okay, can I sit in front of
You can do whatever you want.
Yeah.
He wants to be in the front. You want a chair?
No, I'm not going to stay here. Good evening, everyone. I'm Raja Datta. I'm very happy to be here in Yolo County. I just joined as the medical director of behavioral health. I'm at the stage right now where I still couldn't put in my 2 hours of holiday leave for Labor Day. So that's where I'm at in terms of finding my, my feet. But this is my 3rd month here. Yolo County is, I love Yolo County. As I was saying, when I first came from the East Coast to California, we started off in Davis. And we lived there for about a year. So that was amazing. We loved Davis. Until we found out how expensive it was, right? So then we had to, settle for health. So what I like about Yolo County is that, for example, when I was driving here from West Sac, it's still very rural. It's beautiful rivers. I drove by a beautiful river, farmland. So to me, that's what my vision of California was. I'm obviously, as you can see, I'm not from around here. I grew up in Malaysia. So in Malaysia, I read a lot of John Steinbeck. That was he wrote about Salinas, but that was my idea of what California was is. And it's a close approximation of that, especially if you go down the delta. So that's Yolo County. On the other hand, you obviously got UC Davis. What we liked about Davis was there's a university there, there's a Montague Center there. You could catch opera if you wanted to, or watch a rock concert. That's the other part of this place. It is so amazing. On the downside, this morning I did a clinic in West Sac. So I parked the car and I was walking to our place there. And there were like, I must say about half a dozen homeless folks who were like pretty much resting there, but probably they were there overnight and this was the morning. And there was this homeless guy who had his cart and he had his dog. And the dog was barking at me and I thought, oh great, when he started there, I'm getting bitten by a dog. Fortunately, the man could control his dog. So that's the other part of Yolo County. And I guess in a way, it's a little bit like California. We've got some of the most beautiful places in probably the whole world. We've got a lot of affluent, highly educated people, and we have a whole lot of poverty and a whole lot of homelessness. And mixed into that, of course, there is mental illness, which is what we are about. So that's what Yolo County is, and that's what the challenges of Yolo County is. I guess if we had to point a finger, it would be probably homelessness right now. That's, and of course, the causes of homelessness, and where to start the causes of homelessness. But mental illness is, I guess, inextricably linked with that, with homelessness. The other part of me is that if you look at me, I graduated psychiatry in 2011, so probably some folks will be asking what the heck did I do with my the rest of my life before that? Well, before that, I was a gynecologist.
I thought you were just 35 years old.
Yeah, so before that, I was a gynecologist for 25 years. I practiced in Malaysia and in Scotland. I dealt with a few thousand babies. And so it's not a surprise that part of my interest in psychiatry is maternal mental health. A lot of folks might not know that probably one of the leading causes of maternal mortality, women who die in pregnancy, is actually suicide. It's nothing to do with hemorrhage or infection. It's actually suicide. So we've got a whole lot of unmet needs in maternal health as well. So that's basically me in a nutshell. I'll take any questions if.
So I know this, but I think everyone else will be interested also. You came from DHS, right?
Oh, yeah, okay. Well, my career as a psychiatrist, when I first came to California, I started working outpatient for a while in Davis and in Elk Grove. Then I joined the state of California. I've been in the state of California for about 10 years. I worked in 3 prisons, Stockton. In fact, we actually activated Stockton. I worked in CNF in Vacaville, and I worked in Folsom Prison where I was acting chief of psychiatry there. And after that, I was in DSH for about 5 years. So I went up to being the acting medical director at DSH in Napa. But after 10 years and after 5 years going to Napa, we thought we'd look for something with a shorter commute. So which is why we found, I saw this Yolo County position there. It's been almost about a year since I think I first exercised my interest in the job. So in the end, I ended up here. So yeah, a lot of my experience in psychiatry before this work is in forensics. I understand we have a county jail here. And I guess all of you know that in some ways the biggest mental psychiatric facilities in the nation are prisons and jails. That's where all our, not all, but a lot of our mentally ill end up. It's a cycle. What can we do about it? It's a really good question. For those of you who know the history of this, it started off decades ago when the idea was good, I guess. The idea was that the best place for someone to recover his mental ill is with his own community, with his own family. So they started deinstitutionalizing all the state hospitals nationwide, I guess. I think we started in the 1950s or 60s. JFK actually started it off. But the other presidents following him, I'm not going to go into politics, they did a really good job about it. One good example is I did my residency in St. Elizabeth's Hospital, which is in Washington, D.C., one of the oldest state psychiatric facilities in the country. It was built during the American Civil War. That's how old it was. At its heyday, it had its own train station, the hospital, because they were so big. From there, by the time I finished residency, we had about 200 patients. So over time, all those patients who were there, they all went into the community. Of course, the idea was the money would also flow into the community, to the counties like yours. That part never happened. So again, not to go into politics, but somewhere the funds never arrived. So that's what happened to all the state hospitals. And where would someone who is seriously mentally ill end up? They can't make it in the state hospitals. Usually they end up in jail or in prison. We had patients in St. Elizabeth's who when the lab, we actually had to teach them how to use a bus or how to use a subway. They were so institutionalized. So it's actually preparing them for failure when you let them out in the community. So anyway, what was I talking about again? Kind of got lost.
DSH.
DSH, yes. Our state hospital system in California is actually, relatively speaking, very vibrant. It is doing relatively well. We could be better staffed, but we're not as fully staffed as some of the prisons. And actually, the state hospital system in California, we have actually more patients. The system as a whole is probably one of the largest in the world, if not the largest. We don't have, obviously, we don't have numbers from countries like China, but we have a large number of patients. And we like to think that we treated some of the most sickest patients in California, if not the whole country.
What do you like to do for fun?
Oh, I've gone through a lot of things in my life in terms of fun. When I started off, I like tennis. I trained my youngest, both my sons, but my younger was, I call it better, he played for Sac City. I kind of gave up tennis when I came here because of residency and work. So I like swimming, I like reading, and of course I like ballroom dancing. So with my wife and I, this will be our 40th anniversary this month actually. So we kind of like dancing and I've always liked dancing since I first got married 40 years ago. But at that time it was just like dancing up and down to rock and roll. So we actually started taking lessons about a year ago. So I think we graduated from the beginner to the next level in Rumba, Tango, Cha-Cha. We still have to sit for the foxtrot and nonsense.
He'll be on the next Dancing with the Stars.
I know, right? That would be great. Yeah. Any other questions?
Can I just say a few
Sure.
words? Yeah.
Oh, I should have had you introduce them.
Yeah, that's okay. We have been without a medical director of psychiatry for a very long time. We had an interim medical director of psychiatry for a few months. And we underwent a number of recruitments and really a nationwide recruitment. So eventually we brought on a recruiting firm that we entered into an agreement where they would continuously recruit for this position until we filled it, right? And so we had many folks that were sort of, brought to us as potential candidates, went through interview processes with several highly qualified psychiatrists, and we were so pleased when we met Dr. Dutta. So Sam, myself, and Tony, our children's branch director, who can't be here tonight, he's ill, unfortunately. When we met Dr. Dutta, we were very impressed by his experience. So not only does Dr. Dutta have experience at the Department of State Hospitals, but also at CDCR, so in the prison system. And so, the criminal justice and the experience and the work with folks who have been sent to the state hospital who are incompetent to stand trial, very relevant for us here in YOLO. Criminal justice work is a high priority for us in terms of mental health. But I also loved that he, in his other previous life, was an OBGYN, and he's very interested in maternal mental health, which is sort of a different sort of end of the spectrum, right, when we're talking about behavioral health services, but a really important topic when it comes to mental health, a very important population, and where there's a sort of a lot of energy around that here in YOLO, lots of work with our federally qualified healthcare centers and things like that around maternal mental health efforts. And so, and he's also quite funny, so we really appreciated his sense of humor and how approachable he was. He came with the most glowing references I might have ever seen and has really been a great fit so far. Some of the things just in the short time Dr. Dutta has been here that he's been focusing on has been really, of course, getting the lay of the land, right? Learning our county system. Luckily, Dr. Dutta had some insights into our system because he also worked for GM at Woodland Memorial Hospital. And so he has interacted with our mutual clients who have been on holds there and getting mental health treatment there. So he wasn't completely oblivious to sort of the positives and maybe the opportunities for improvement, in our mental health system. And so he comes with that perspective, which I think is very important around how we can improve. And he's also seen patients. So he he does part-time see patients, and he's actually seen patients in our West Sacramento office, which is wonderful because prior to his arrival, we did not have any in-person psychiatry there. We had telehealth only. And so it's so wonderful to have someone one day a week providing psychiatry in West Sac. So that's been really great. And then the last piece has been that we are bringing him in to help with some of the oversight and support over our contract with WellPath for jail health and behavioral health. And so most recently, some of the things I've drugged Dr. D into has been, we've been coordinating within the jail and with the jail behavioral health staff around involuntary medication orders, something, I worked with Jonathan a bit on before he left, but that he was certainly interested in. When, those are when individuals are decompensating significantly and where court intervention is warranted to attempt to get an order for involuntary medication administration, which would happen by the WellPath and jail staff. But we have a review process in that. And so Dr. Dutta recently reviewed several requests, provided really great insights based on the medical notes that were reviewed. And it's wonderful for me to have sort of someone else to be a part of that process. And his insights were far more valuable than mine were. So I really appreciated that. And so I think, it's month 3, but it's really just the very beginning of his 3rd month, and I think he's just been a wonderful fit so far. So I'm very excited to have him and to be able to have him come and meet the local health board. So I'll stop talking, and I think Kimberly had a question. Right? You started to raise your hand before I talked, yeah?
Yeah. So I guess my question was, how have you incorporated mental health consumer feedback into your previous practice? And how do you envision that and incorporating that into what you're doing with the county?
Well, in my previous practice, I work for the state, so in the Department of State Hospitals, in terms of consumer feedback, we had patients' rights groups. So basically, I guess, in a way, that's how we got our consumer feedback. And the state hospital system, we try to work with our patients' rights personnel as closely as possible. In fact, the latest initiative before I left was that if we had any new meetings about patient care, that they would incorporate the patient's rights personnel there. And in my experience, I think I found the patient's rights folks really easy to work with. They have a lot of insight, and we love working with them. The other part, of course, is we have patients' families. We would have regular monthly meetings with patients' families, and they would bring up their own concerns about their son or their daughter. Usually their son. Most of the folks who are what's the word for it? Who are committed legally to a large proportion male, I want to say, with about 80-90%. That's an average. So yes, so we would have monthly meetings with the patient's families in terms of they would bring up their concerns about medical issues with their children. And I want to relate a few direct consumer feedbacks I got. So when I was in my office, I can't remember whether the chief of psychiatry or the medical director, someone called and I picked up the phone. It was a patient's mother, and she spent the next half an hour telling me how terrible the doctor was. actually the local who her son was, I looked him up, that the Napa State Hospital should be closed down, the governor should come and sack all of us, and so that was about half an hour. Of course, tried to empathize with her and ask her what, her son, what was I guess the main reason she called, and family, she wanted the son to get some food. Just fine. So just did some calls and said, hey, if you get some, she wants to bring some food for the son. So that's, I get one kind of direct feedback I got from a consumer. It wasn't very pleasant, but it's a state hospital. So I don't know whether that answers your question.
Well, I think, I'll just add in, I mean, I think that the difference, right, in working in a system like that and working, and now being here, is that we are providing community-based services, and there's far more opportunity, I think, and systems that are already built, and certainly systems that we can grow, and I think improve upon, right, where we are really intentionally eliciting consumer feedback and considering that in how we build out our services. So that's an integral part of the Mental Health Services Act process. It's certainly parts of our state audit and review processes where they hold consumer focus groups and focus groups for family members, and that feedback is incorporated in how we make decisions at a larger level. And I think, where my wheels are turning with your question too is like, how do we, make that a feedback loop all the way through to our prescribers? Because I think that part can get missed sometimes. So I'll spend some time thinking about that certainly. But I think there's just more opportunity for that here.
Definitely, there's a lot of, because it's
Yeah.
community-based, The state hospitals, we have, and obviously we try to work with the families. In prisons, that's an entirely different proposition. So there, security is number one. So I guess I don't actually remember talking to any relatives of prisoners there.
Okay, yeah, thank you.
Welcome.
So, Dr. D, from the criminal justice standpoint, you'll learn YOLO does a pretty good job of really doing our best to decriminalize those who are in the system because of substance use disorders or mental health issues. Coming from the DA side, we always have to think public safety first, just like we were saying in the prisons. But we have some really amazing collaborative courts that we've started here. Chris, who is still the DA's office, and he oversees all those collaborative courts. And unlike the rest of the criminal justice system, the traditional, where you're fighting, and it's oppositional. In most of the cases, the team, which is Health and Human Services and probation and the DA and the public defender and the judge, are all kind of rowing in the same direction. So I want to, and I know Chris was probably going to talk about this later. I don't know if you're going to stay longer. You don't have to, but you're more than welcome to. But I just want to invite you to, so we have this program is generally, a lot of people that go into these programs, but for these programs, and if it were 10 years ago, they might be at a state prison, okay? And we're giving them a second chance, right? And it's been working. We've been taking risks, for the DA, law enforcement is very risk averse. We've had a lot of success because of the amazing team we have in terms of providing, the wraparound services and support. And so we have graduations maybe once a month. The program is like 18 months to 2 years to graduate with all these different phases. So we have a couple graduations coming up, and they're very, very powerful. And I'd like to invite you and everyone else, of course, like we always have, to a couple graduations that are coming up. I happen to reach out to Terry to ask when those were. I don't want to rain on your parade.
Well, I have the two for this month.
Yes, that's what I was going to ask you.
So there's a AIC graduation on September 13th at 2 o'clock in Department 6. And we have a mental health court graduation September 16th at 2 p.m. in Department 5. Those locations can change if the judge isn't available, and another judge covers it. That's what they're set for right now.
And maybe we'll try to get an email to everyone, like the week of that second week in September. The AIC is Addiction Intervention Court. As you can probably guess, a lot of times you don't know where to put them, and sometimes we move them from one to the other, depending on where the most prevalent issue is, whether it's substance use or mental health, but often it's co-occurring, as you know, of course. But yeah, so there'll be others coming up. I know you're busy. So they're at 2 p.m. They're at the courthouse. They're not that long. You can get a piece of pizza
Oh.
and cake. So there's a cake, yeah.
We'll be there.
I've got attention.
Yeah. So have any of you been to one of these graduations?
Yeah.
Oh gosh, a lot of you. Yeah. So they're pretty powerful, huh? Yeah. So we'll get you
Thank you. Yeah.
we'll email you the dates.
I kind of had a question. I know you haven't been here that long, but what do you see as the needs of this county for psychiatry? I mean, I'm just curious.
I think the needs, I would say the needs are actually pretty diverse in a way. Mental illness is not a single thing. It's like physical illness. You've got from the head to the toe. And the reason I'm saying that is because the patients I saw in Westside, they are, in fact, one of them actually graduated from the program. This first visit. They have, substance issues, and then they have a whole history of trauma, and then they have legal interaction. So that's one subset of patients. And in this subset, the aim is to provide safety and also to make sure that they don't fall through the cracks in terms of treatment. So that's one. The other one was yesterday, I was talking to the chief of psychiatry at UC Davis, and he had students there, a whole bunch of students, and they have their own issues as well. And one of them was, he asked whether we prescribe medications for ADHD in our county clinic, right? And I said, well, I don't know whether the psychiatrists there are really do that as a practice in our community, in the Yolo County community clinics. But it's a good question because if students, academic grades must be met, there's a lot of pressure, so a lot of them do, and of course ADHD. So we've got, it's difficult to actually have a one size fits all kind of answer to that question. Mm-hmm. I think for us, the most pressing one would be the ones where we have to treat them. I don't like calling it serious mental illness because that kind of every other mental illness is not serious, but serious mental illness, like patients with psychotic disorders, patients with serious mood disorders. They are the ones who tend to deteriorate the fastest and get really decompensate really quickly. So those are the ones you need to catch. And at this moment, I think, and I'm not saying Yolo County is the only one, the whole of California, the whole of the US, we could do a whole lot better with this group of patients. So I think if we have to focus our attention, we would have to focus on those, like the clients I saw today.
Well, the reason I'm asking is because I have a family member who had to was within the Yolo County mental health system and would complain to me often about not being able to see a psychiatrist on a regular basis or not have the same psychiatrist follow them for a long period of time. And I'm just concerned about, the way services carry over, and or wrap around the person. And that just to me, I think seems very important.
I agree totally. It's continuity of care is vital. I mean, and it's not only for our patients, for us as well. I want to see the same doctor if I can, because I've already told the story. I don't want to retell the story. I know this doctor knows what I have, and it's the same with our patients. And we do have a good group of doctors right now who are seeing patients. A lot of them are doing telehealth, and I think they started off during a pandemic. And telehealth itself has got its advantages, but at the moment we're trying to find that happy medium of getting more doctors to see clients on site. And hopefully do a better job at making sure that they get their appointments correctly. And I want to say that from what I've found out from, for example, the one in Woodlands and the staff, they're pretty good at this. And in fact, the client who came today, the staff was amazing. They picked the client up from the home, got them here, made sure that they came on time. So I think we do a pretty good job on that, but we could be better.
And if I can just add, Sarah, I think, we have a pretty small prescriber team, mostly psychiatrists, one nurse practitioner. And it's about a split between them being county staff and being contracted providers that we contract with through basically a staffing agency for mental health providers and psychiatrists. And I think we found that we were leaning more heavily on the contracted providers, especially during the pandemic, while we were without a medical director. Part of, I'm not a doctor, so I can't speak for doctors, but some of the feedback that I've heard from our prescribers has been that there is quite a lot of fulfillment, right, that they get from their work, from seeing patients. But there is also this culture of learning and of continuous learning and continuous education in the field that is also very important to them, so they can feel like they're continuing to grow as psychiatrists. And that piece was missing for us because we didn't have a medical director of psychiatry. So while their buckets might be getting filled because they're working with clients that they love and they love serving this community, that piece about sort of growing in their own work and staying apprised on sort of advancements in their field really fell to them alone, right, as individual doctors, as physicians. And we were missing that sort of leadership part. So that's something that Dr. Datta is also focusing on. So he's bringing in some CMEs that people can do virtually, that we can host within even meeting rooms weekly for people and things like that. So sort of bringing some of that back, because we had lost that without a medical director. But I think we do have a core group of psychiatrists now who have been here for quite a while, actually, who are very invested in our patients and in this community, and in really staying here, which I think is great. I think part of some of the work ahead for Dr. Datta, probably through the end of this calendar year or beyond a little bit that I can see, is getting, now once he kind of gets a good sense of how things are going, what are our access times looking like, what is our calendaring looking like for medication support appointments, to then do some strategic sort of planning, right, around what do we want our provider array to look like. And while we have wonderful contracted providers who have been great, and many have actually stayed on for a long time, we would prefer to have county staff, right, and have them be a part of our county workforce, and to have a bit more stability there, so maybe leaning more toward that. So I know he has a few people he has in mind to recruit and maybe steal over, which is wonderful. But really getting a sense of what we need so that we can have a provider team that really meets the needs of our clients. And it is a difficult balance to strike between telehealth and in-person services, because psychiatrists really have their pick of the litter. They can work telehealth jobs and work from home. There's more jobs out there than there are psychiatrists, right, for telehealth. So it is very difficult to find providers who want to come into the office. And so we're really trying to strike that balance, because for what we know for our clients is that that's important.
Yeah.
Having that in-person access. For some people, telehealth once in a while is okay. But for many of our clients, they would prefer to be seen in the office and be seen in person. And so we need a workforce that can be responsive to that, and that is difficult, because it's not, that's not the preference of many prescribers when they can work from home. So, I think that's some of the challenging work, I think, for Dr. Dutta in his leadership position, and just kind of getting a sense of our system, and then figuring out, how to recruit the workforce and create that team that we need. We are pretty much fully staffed right now in terms of psychiatry. We had a nurse practitioner lead who had been here for a very long time, a few months ago, but then Dr. Dutta came on and he's seeing patients. We've retained some of our contracted staff, so we're not having access issues to psychiatry right now. In fact, I didn't get to some weeks and there are still available appointments on the calendar. So there's not maybe the kind of delays that we've seen in the past when psychiatry when we were sort of, hurting, right, or had more vacancies there. So I think it's really around what's the right mix, for the team, and who are the right people to bring on who can show up and who are willing to do some, work in person, because that's what our clients really want and need. So hopefully that's helpful feedback, yeah.
And just to, sorry.
Oh, I didn't really have a question. I just wanted to make a comment.
Oh.
My perspective is as a parent of a loved one who has dual diagnosis of SUD and schizoaffective disorder. Was missing for a couple of years out of state. She's finally been conserved under LPS conservatorship. Unfortunately, her delusions involve family. And so she's been there almost a year, and we are not part of the plan at all. Like, I don't even know where she's at in her remission, if she's reached remission. So basically, we have to rely on the system. I've been told to just try to trust the system. But I have to trust these doctors and everybody behind the scenes to make the right decision. So I hope that as you guys are planning, and as you're thinking all these everything that you're doing, please consider the process for that, where we're excluded. I have no idea what's gonna happen to my daughter when she gets out, possibly next month. She might go into a step-down program. So just think about that when you're working with people in that particular, environment, because I'm relying on you guys to make the right decision for my child, even though she's an adult. And obviously, she must not be that well because she hasn't even called us in a year, or her son. I'm raising her son, which is very unnatural for her. So just think about that, working with that population. So I guess I do have a question. Would you be working with that population and overseeing some of that? Yes.
Yeah, so Dr. Dutta, so I think it's probably important to sort of explain what, so as the medical director of psychiatry, we do have direct service sort of expectations around that. So he, like I said, he does work in clinic 1 day a week, and then it is his job to supervise all of our psychiatrists and prescribers. That would be any psychiatrist on staff, but also, and if we have nurse practitioners who are prescribing psychotropic medication. And to really oversee that medical component, right, of our behavioral health work. So he's not over our therapists, our case managers, but really works in partnership with the program team, is specifically tasked with overseeing the doctors, right, and the prescribers. And so, yeah, we do provide services for some. It depends on where they're placed and where they're getting their services and whether they're continuing to get services here. But our behavioral health team does work very closely with our public guardian team, and actually even more closely, I'd say recently, where we're taking on some clients within behavioral health that previously would have been sent to our FSP provider, to ensure that continuity of care and level of service. So it's a bit of a new role for us. I don't know, Sam, am I saying that right? Like, just
I think
more
it definitely
recent
has been
change,
something
yeah.
more recently
Yeah.
since the pandemic, that's definitely been a change.
Yeah.
Many years ago, that was sort of the approach that we took also.
Yeah.
But,
So there's a lot of coordination and overlap, and so, and we know that our clients who are on LPS conservatorship are the most vulnerable adult clients in our behavioral health system, because they've had to be placed on conservatorship, right, to get their needs met and to ensure that they're accessing the services they need. And I think, what's coming ahead is we have care court implementation coming in December for us here. We have SB 43 implementation coming January 1, 2026. And so I think Dr. Dutta will become more and more involved with some of that as we start to do more of that work toward implementation of those efforts, which are very closely linked to our public guardians work as well.
Thank you.
Thanks, Sylvia.
And I was just going to say, someone mentioned about continuity of care. And there's always an ongoing challenge with recruitment and retention of psychiatrists, and it's not just Yolo County, it's nationwide. When I was in Folsom Prison, I used to say that we have more psychiatrists in Folsom Prison itself than some US states, like Wyoming or Montana. They have like 20 psychiatrists for the whole state. So, and the median age for psychiatrists is going up. I think it's about 55 to 60. So they're aging out. So, but there are no new psychiatrists. There are psychiatrists coming in, but they're not as much as you. So when I was recruiting in ESH, we had those ethical considerations about stealing psychiatrists from other states where there's a bigger need. But then, we have a need ourselves, so of course.
So welcome.
Oh, thank you.
Yeah, and thank you for seeing patients. It warms my heart to know that someone who's going to be making decisions supporting other physicians is actually working within the system. I think that's really important, so thank you for doing that. I don't really, I have tons of questions, so I won't really ask any because I can't decide which one is the one I want to ask. But I do want to say just to the group, and I'm used to in my job having a diet partner, so I was a chief medical exec. And in the last 5 years, I've seen what strong physician leadership can do to change, not just policy programs, but just in physicians, when they feel supported, they come to the table very differently. And so I'm glad that you're in this role, and I would love to see some sort of, I don't want to create more reporting, but just some update, just so we have a sense of what's happening and how you're supporting the physicians in the programs, because I think there's a lot of great work that I suspect you'll be doing, in partnership with Carlene and her team as well.
Yeah, I look forward to it.
Could we maybe have that as like an ongoing section of the medical director's report that Dr. Dutta could help you?
Absolutely, yeah.
More duties as assigned.
Yeah.
Yes.
Well, thank you very much, and please stay with us, or if you have to head out, I think Kimberly has another question.
I just kind of one last thing. Like, thank you so much for coming here and sharing your perspective. Like, just both of kind of your own background, how you see accounting, how you see its needs, and kind of like piggybacking a little bit on Melanie's point. So I'm sure you already know, but just kind of reiterate again. The county mental health system has an enormous personal impact on the people that encounter as consumers, on the families, on the community. And I hope kind of in going through this, you really keep that in mind, because we're just kind of a sampling of the people impacted by this. Like, a lot of us, their motivation to be here is because of like the deep interpersonal impact like the mental health system and also mental illness has had on our families' lives and our lives. So we kind of go home with this. It's not something that's just a meeting to us. So I hope you keep that in mind as you kind of go into.
Absolutely, yeah. I read somewhere, and you can check me on this, on the psychiatric textbooks, that schizophrenia itself, one disease, it costs more money and it occupies more beds than all the cancers in America combined. So the mental illness is needed to take it more seriously and put more dollars into it.
Thank you for being here, Dr. Dutta.
Thank you.
Thank you all.
All right, I'm just gonna open it up now, since that was a very interesting, robust conversation for public comment. Any public comment from our people that are here?
I'd actually love to ask a question. And I know that there's already a lot on your plates with individuals who are, seeking mental health services.
So I want to stop you. The public normally procedures, they don't ask questions, they make comments.
Oh, I
But
see.
we might be able to, we'll see what, but generally it's just for comments.
I see. Okay. No worries. Can I ask?
Yeah, you can,
Okay.
you can ask it.
All right, and then if you choose not to answer those, I guess that's fine if it's not practice. But what we see very often with the clientele that we serve is that they have mental health needs, but they're coming from countries or histories where mental health is very stigmatized. For example, a few months ago, we had an elderly woman come from the former Soviet Union. So she grew up in a reality where if you are diagnosed with a mental illness, you are revoked your driver's license, and there's a lot of legal repercussions to having mental illness. So she refused to seek care, even though she desperately needed intensive mental health services. So I'm just wondering if that is part of your outreach program or part of the practices that you normally do is create programming for those that are opposed to mental health but need it.
Can I piggyback on that? It's a great point because I know there are still some countries, for example, India and Iran, where suicide is a criminal offense. So if someone attempts to commit suicide, if they survive, then they might get arrested for a crime. Yes, it is a lot needs to be changed.
I'm happy to provide a brief response. Thank you. Okay. Hi, I'm Carly Jakowski. I'm the mental health director for Yolo County and the assistant director of the Health and Human Services Agency. So you bring up, I think, a really good point. And, there's quite a lot of emphasis on doing outreach and engagement and stigma reduction activities through our Mental Health Services Act work. So there's specific funding that we get through the Mental Health Services Act. A portion of that funding goes to outreach and engagement strategies. For Yolo County, previously our threshold languages were Spanish, Russian, and English. We do have a bit of a geographic Russian population, specifically in West Sacramento, but certainly throughout the county. And so there's a number of ways that I think we try to achieve some of what you're talking about. So through some coordinated outreach and engagement activities at different community events and things like that, but also working closely with our contracted providers, nonprofit organizations, and federally qualified healthcare centers in the county, because they are really generally located in the communities they're serving, matching the cultural and linguistic needs of the community that they're serving, and they're trusted agencies, right, by the communities. And so our local FQHCs have really been working to build up their own behavioral health capacities. And so, for example, in West Sacramento, there's a small FQHC, Elika, and they tend to be an agency that really tries to serve the Russian community there. We have community care health centers, also an FQHC, North Valley Indian Health, which is an FQHC, and then Winters Healthcare Center. So there's a number of FQHCs in the county. I know they're all at different sort of, I think, places in terms of building up their own behavioral health capacities. Some much more robust than others, but certainly all sort of there for all of them. And then we do our best to ensure that we're able to provide those services for those who meet our criteria as the county mental health plan, through having clinicians who are culturally representative or speak the language, and then using language interpretation when we aren't able to meet that, which isn't ideal, certainly in service delivery, but definitely a last resort when we don't have someone maybe who meets the specific needs. So, I think in general, I think what we see locally is that there is some resistance to coming and accessing services for different populations because of stigma, because of fear. I think our experience has been that what's happening at a federal level can have really deep impacts locally, right? We had a wave of folks refusing even to come and access basic benefits that they can get through social services because of the public charge issues under previous federal administration. And so, all of those things I think have those ripple effects through our community. And again, our Mental Health Services Act funding specifically requires us to do some direct outreach and engagement, which we tend to really take quite seriously. So hopefully that answers your question a little bit. Yeah.
Any public comments from people on Zoom? Okay, hearing none, we will move on to the Mental Health Director's report. And what items would members like to pull?
Okay, I'd like to pull a B, and just say thank you for asking.
Any others from members? Okay, let's start with A. What was your question?
My question is now what happens?
Yeah, such a good question. So therapeutic foster care is a Medi-Cal benefit counties are required to implement. And as we shared in the last meeting, that was a big focus of our recent audit, where they really focused on the fact that we weren't providing that service, right, or screening for that service. So the next step for us is to have some conversations with our county procurement department, which is through, under our Department of Financial Services CAO's office structure, to talk about what are our options. Because what some other counties have done when they've not gotten responses specifically for TFC, therapeutic foster care, is they have moved to what they call an open enrollment process, where they can contract with any provider who comes to them and says, I'm willing to be a TFC provider. And sometimes you have to get through, for some county procurement policies, you have to go through a competitive process first, get no bids or have no resulting contract, to then be able to have these more sole source kind of agreements. So that's the next step for us, is to work with procurement on getting some direction around what approach can we take moving forward. Can we do an open enrollment process like Sacramento County is doing, for example, and some other counties? And then it would be around doing some direct outreach to foster family agencies around trying to develop a contract. So there's a lot of trudging through the mud, it feels like, in terms of the next steps. There's no easy answer here. Concurrently, foster family agencies are facing some pretty tough, they're in a pretty tough position. The primary insurance company for foster family agencies has decided to no longer insure FFAs. And so many foster family agencies are trying to sort out sort of what that looks like for them in terms of having insurance. And so it is actually a bit of a crisis, I would say, that's sort of brewing on the social services side of things, which I know Tony's been really looped in on. That has a direct impact here, because therapeutic foster care is generally provided by through foster family agencies that have foster homes. So it's a bit complicated. But our hope is that we'll be able to get the green light to have an open enrollment process, and then we can outreach directly with perhaps providers within the region who we know are doing therapeutic foster care in other counties neighboring us, so that we can start getting some agreements in place. So those are the next steps.
Because it sounded like you and Tony didn't necessarily think this was a great thing for the kids anyway. So
Yeah, I
how
don't.
much trudging do we have to do
Yeah.
if you don't even think it's a good idea?
Yeah, I don't necessarily think it's a great thing for the kid. I have a lot of opinions about therapeutic foster care, and I'm happy to get on my soapbox about it or not. But there's no real evidence behind this being a beneficial arrangement. We are actively working to keep kids out of the foster care system and not have them go into foster homes. And it's also this model is really missing a large component, which is the board and care cost of a child going into a foster home, which is not a part of the Medi-Cal benefit. So there's no payment mechanism to pay families to actually house the kids. So it's very complicated. It's quite broken. On that side of things, we've actually reached out to CBHDA, the California Behavioral Health Directors Association, where I'm on the executive committee. Tony chairs the children's subcommittee, and we're trying to convene a number of counties that have lots of points of contention around this benefit to have some direct conversations with the Department of Healthcare Services about our feedback. San Bernardino County, which is geographically the largest county in the state, I think has had less than 20 children access therapeutic foster care since the benefit went live several years ago. So it's a lot of work for not a lot of utilization. I don't think there's a lot of data to show that it's successful. And I'm hoping that we can bring that to DHCS and have a conversation. And yeah, so my opinion is that it's not great, but we're required to make efforts to have this benefit in place. And so we're going to continue to make those efforts. Because otherwise we face fines and sanctions as a result of it. Yeah. Which I certainly wouldn't want us to have a fine imposed on us for not having a benefit available, even though I sort of take issue with it being a benefit to begin with. So those are conversations for me to advocate appropriately with the state, and I will do that. And we'll still follow through with our efforts to try to have a screening process and potentially a contract for if and when we need that service locally. But I think it will be a long time before we see that actually come to fruition, if ever. Yeah. yeah, our experience is that there's not really a lot of foster family agencies that want to provide this service either, so it's very challenging.
Okay, Sue, mobile crisis data.
Oh, mostly, do some.
Sorry, I had a question about that too when you're done, just,
Oh, this
they
one.
didn't say
Practice.
anything, so, yeah.
Mostly, I just wanted to see if there were any numbers you wanted to highlight, but also I was hoping one of those numbers would be June. Because why is June so much lower than all the other?
Yeah, that's a good
It's a
question.
very good question, and I actually think it has to be a data anomaly, but I don't know that for a fact, so that's my, like, I'm looking at it now, it's interesting how when you look at something in front of other people, and you see things, and it's like, oh, yeah, I probably should have looked into that, but for me, you know, it's, yeah, I would need to go back and also look comparing to, that's the only thing I can think of, but I'll take a look at that.
Yeah, yeah, certainly something for us to look into. I mean, the after hours numbers, they're somewhat consistent besides April, I think, with a spike. So really it's the daytime contact that I think is significantly lower, you know, for June. So,
And it also could be a staffing issue that we had in the month of June. You know, I know that we did have a couple of staff off at the end of the school year and things like that, but I don't know that that would account for more than, 50%
Yeah.
drop.
that's a big difference, yeah. Yeah, so you did ask, if there's anything to highlight. I think what I'd just like to highlight is the percentage of non-Medi-Cal beneficiaries that we're serving with this benefit, and just to remind everyone that we don't get reimbursed when we're providing services to non-Medi-Cal beneficiaries. But, when we launched this benefit and launched this project, we knew what the right thing to do was to serve anyone regardless of insurance status and not to screen people out based on their insurance status. And that we have some work to do internally to be able to bill. I will say that I was just reading some feedback from another county, and other counties who do have the capability to bill commercial insurance for mobile crisis are finding that they're going through all the work of billing and they're still not getting paid for those visits. And so my inclination is that even if we could bill for these services, we likely wouldn't be getting paid for most of them. So there, I think, is some work to be done at a state level to really have parity there, right? Because we should be able to serve anyone regardless of insurance status, and we should get paid for that, right? And that would actually really help us in having a sustainable program here locally. So I think that's one of the data points that I would highlight. It's just that, it's a pretty significant 36% more non-Medi-Cal, and those aren't people that like snuck through the crack. We're serving anyone regardless of their insurance status, which is the right thing to do.
So where is that money?
There's no money for it.
No,
So
but
yeah.
I mean, like, is it
Yeah,
general
how are we
fund or-
doing for it? Yeah, so, right, we fund the majority of our crisis system through Mental Health Services Act, which is gonna be interesting to see how that unfolds with Prop 1 implementation coming up upon us. And so we leverage MHSA as the match for Medi-Cal. Right now, the Medi-Cal benefit is actually pays I'm gonna oversimplify this, but for us to draw down that federal entitlement, the Medi-Cal, the federal portion of the dollar, there's always a local match, right? There's a local dollar, or local money that you have to match to draw down that benefit. For the first year of the Medi-Cal mobile crisis benefit, there's no county match required. And so we're only getting that federal benefit and not having to put up the county match, which is very helpful as we build up the program. So I think that's helping offset some of the costs of what we're seeing for non-billable services. And for us, that local matching dollar, we use Mental Health Services Act funding for that local match currently. I'm not sure what that will look like in the future, but for right now, that's what that looks like. Yeah.
So a couple things on that.
Yeah.
I'm curious for the data, did you look at to see if repeats, so maybe that there's clients or people.
High
who are-
utilizers?
Yeah.
Yeah, I mean, that's certainly data that we have available to us. We've looked at it at different times in different, programming, especially when we look at hospitalization and things like that. I don't know that it's something specifically that we've looked at with mobile crisis, but it's certainly something. I mean, I know that our staff are very aware, like at a staff level, right, of folks who use our mobile crisis services more frequently. But there's not any data that we've pulled at a systems level to look at that. Yeah.
Because you could start to see some people using this like their ER, right? it could start, and I'm not saying that we shouldn't support that, but it would then lead us down a different path of maybe a solution, which might be a partnership with these non-Medi-Cal, right?
Yeah.
So if we're finding that the non-Medi-Cal population is high utilization or repeat, is there a way to partner with
Yeah,
whoever their provider is?
yeah, that's
That's a great,
it's a great point.
Because, yeah, I don't know,
Yeah.
could be that it's one.
Yeah, we have to look at the data to know.
Yeah.
Yeah, I think that's a really great point, thank you.
And kind of just expanding on that, are there recent stats about that reflected? Like, are there recent stats about repeat clients?
No, we're not reporting out on, like unduplicated client count at this point. It's certainly a data point that we can report out on.
the other thing too that we need to really be mindful of is with
Our
such
numbers
small
are so
numbers
low.
initially, really to be committed to the confidentiality. And so once we're able to have larger numbers for the aggregate kind of reporting, then that's something we can do. And I think, if I may just also say, is that we've really been focused on the implementation and the rollout of the services and kind of getting that workflow going, more so than we have focused on developing sort of the intricacies and the nuances of the data. And so I really appreciate the suggestions. And that's kind of like a next step that we're really going to be working on, and also trying to make some modifications where we can to our electronic health record to assist in being able to efficiently and effectively pull that data. That's been one of the challenges as well.
And the other thing I was going to ask, are there recent stats on number of 5150s that are just initiated by law enforcement and not by mobile crisis? Because even with this going on, the police are enacting 5150 holds when mobile crisis isn't available. So are there recent stats on people that have been 5150 just by law enforcement and that have not had a mobile crisis interaction?
Yeah, I don't think that we have any direct data. Sammy, you'll have to chime in if I'm wrong, but we don't have any we don't receive data from law enforcement to say, these are all the 50, I'll give a caveat to that after this, we're working on it. But we currently don't get any sort of regular sort of reporting from our law enforcement partners around these are all the 5150s, especially with client level information. For us to then cross-reference whether or not we've had a mobile crisis response. The caveat to that is that there is some legislation that passed that requires county behavioral health to do quarterly reporting on LPS holds on 5150 data. And so we are working to build up infrastructure internally to ensure that we're getting accurate data from all of our partners who write 5150 holds. We've gotten pretty good data from our hospital partners. They're working on it, and but we have law enforcement, we have other folks who are certified to write 5150s, and so we have to build out a process. And unfortunately, there was no informed sort of consultation or work with county behavioral health before this went into effect. And so every county sort of scrambling to make sure that we can get accurate data and report out. But I do think that one of the things that we would be able to see more clearly in the future with that data is exactly what you're asking about, which is like, how often are 5150 holds being written, but there wasn't a corresponding mobile crisis encounter with a mobile crisis team or clinician that was part of that process.
I'd also like to take a look at it and how it relates to the amount of CIT training that we're providing. With an increase in training, are we seeing a decrease in those?
Well, they'll have to also be carved out for gravely disabled, right? Because you're gonna see more 5150s for gravely disabled, which may or may not, right, require intervention. It might be a different intervention, especially in the elderly population. So it'd just be interesting as this all starts to unfold.
And part of the reporting is on the reason for the 51, right? The reason for the, I'm trying to remember what's all in the data. There's demographic data, there's the type of hold, the length of the hold, whether the hold was extended.
And also repeat.
Yeah, how many people had a repeat hold within certain time frames. So it is,
So when you're building out that system, are you now going to be able to see when minors are supposed to hold school and track that?
yeah, so minors, the data is for everyone, so it's not just for adults. So we would, and that's, I think, in some of our early reporting that we've had to submit, I think that's where we can do better, right? Sometimes we're getting data that's not very specific in terms of demographic information, and so we can clearly see where that can improve. It's also very interesting that the statute and the corresponding requirements from the state require the behavioral health directors to submit the data themselves. Like, I have to input the data into this website, which is very interesting. I was very annoyed by it at first, and I will say, a benefit, don't tell them I said this, a silver lining maybe to force, requiring that we're the one to actually do it. It doesn't say or designate, it says behavioral health director. It's quite eye-opening, right? I mean, and truly looking at the data and having to input the data and going, why don't we know some of this demographic information for this many people? I think it is actually in some ways helpful to see. Don't tell them I said that, because I think everyone's sort of pushing back on the behavioral health director having to input the data themselves, but it's quarterly data. And we, again, I think our first two submissions we know that they were not full complete because we know we didn't get complete data from all of our partners, but it's definitely improved. Even from the first submission to the second, we had really significant improvement. And this data, as long as the data sets are large enough, that's some data that we can bring back to this body and share, and it sounds like that would be very interesting to folks. And so as we improve that process, that's something I can build into future reports.
Yeah, because remember, we had that spike in children's hospitalizations,
Yeah.
and then it was like, well, is this a spike, or
Yeah.
do we even know if this data is good? So,
Absolutely, yeah. I think this process is gonna help us really refine the data, so I think that's, a benefit to this. And we should know about the 5150s that are being written in the, right? I mean, so,
Exactly. Yeah, because why I asked about, hey, how many 5150s are law enforcement specifically
Yeah.
writing versus mobile crisis, because the whole point of Crisis Now and mobile crisis is to reduce
Yes.
law enforcement interactions when that's not needed. And if functionally law enforcement is still responding to calls that the mobile crisis could be responding to, then is it really serving its full purpose? It was kind of what I was wondering. And the other thing,
and sorry, I just wanna say one thing for and our data for our global crisis, for our co-responder clinicians shows that a very, very, very small number and percentage of contacts with our mobile crisis team result in a 5150. It's very, very small, right? So we know that if there's, the lion's share of 5150s are not being written by our staff. So I think that that's pretty clear to us, and we can make that direct connection.
and the other thing I was gonna ask regarding the quarterly reports, 5150 data for the county,
Yeah.
will that include data from the UC Davis campus?
It should.
It should.
It's not currently, but it should.
And that's, and so as Carly mentioned, that we've been working with our different partners to increase their ability to report as well, and they're developing it. We certainly have been contacted also by the university to request some additional training for them, so they have definitely expressed an interest.
But don't they use fire as they use fire as their mobile crisis?
Not for crisis, if that makes sense. For kind of minor mental health calls, yes, but for a crisis, it's police responding. Yeah, so for a hold, it's UC Davis police, right?
Yeah, they have the UC Davis police.
What is it?
I forget what it's called.
Health 34,
Yes.
their
I
van,
was gonna say
like,
36.
their paramedics in that van do not have the ability to write holds.
Right. Okay.
And there is, I think, a lot of opportunity for us to partner more closely with UC Davis, because we weren't really informed about Health 34 until it was ready to launch. And so I think we're building stronger relationships with UC Davis. I think there's a lot of opportunity to strengthen that. They've recently reached out and inquired about CIT training in particular, which we think will be very beneficial. And we also want to partner more closely with them just around mobile crisis in general, because there's certainly a bit of overlap between what I think they're trying to do themselves and what the county is working on. And so we're hopeful that there can be more coordination. And Supervisor Frericks has been very interested in that and really pushing and helping to sort of make some of those connections between the county and UC Davis.
So the only question I would ask, and not for an answer, but just more rhetorical, is it necessarily a good thing that there are less holds?
Yeah.
You know, because, and that's a long conversation, but there are times when family members know they aren't the experts, but they have a good feeling that the person should be placed on a hold. And then the person coming out to place them on a hold feels they don't meet criteria, you know? And then sometimes with even police, it's, well, the hospital's not gonna hold them anyway. They're not gonna, you know, so
Exactly.
I'm
Thank
just-
you for that.
yeah,
That's a
I'm just
very,
asking
that's a very
that,
important.
just a question.
No, it's a great
I was
point.
thinking
But
the
I
same
think that's
thing.
where the repeat calls would also help with that, because you'd see if there is trends.
But they disappear so quick. They disappear and
And,
then.
and I'll just say, and I think for us, I think it's a great point, and I don't think there's I think that's a difficult question. There's no answer to it, right? 'Cause I think in some cases, yes, it is great that a hold wasn't right, and in some cases, no, it probably wasn't the right decision, or someone needed more intervention. You know, I think for Crisis Now in particular, right, our receiving center, I think again, is that missing piece of this puzzle.
Yeah.
People can't be on a hold and go there, but the point is to engage folks in services before they need to go on a hold, right? And to try to stabilize the crisis and get them engaged with services. And so I think that getting that in place is going to be quite helpful for us in terms of getting some more robust intervention, because a mobile crisis encounter by itself isn't necessary. It isn't necessarily, it's certainly not an up to 23-hour intervention like the receiving center would be, right? So we know there's more that can be done.
What's our, let me just follow up on
No,
that.
totally fine.
Just a really quick follow-up.
Yeah.
Remind me the timeline on the.
Yeah, so late summer to fall of next year. So we are, making good progress. I mean, we're saying summer. I want to be realistic. I don't, so I like to add in fall, just in case. But we have a contract going to the board next week around the secondary architectural design, because we are doing a brand new building. The site has been confirmed. And that will actually happen much more quickly than a renovation of the existing building that we were previously thinking of. So we're also concurrently working on getting a request for proposal out for the operations of the facility. So that should go out this fall. And then we would start our agreement with that contractor very early on, so they can actually help us with some of the later sort of design and setup elements of the building, because they'll be operating the facility. So we're making good progress.
And if you need some help scoring those, I'm sure.
We would love to have someone from the local mental health board on that panel. Yeah. So once
They
we
volunteer.
get it out, what we usually do is we contact Jonathan and say, can you reach out and see who'd like to be a part of it? And so we will certainly do that.
Great.
Yeah.
And clarifying on something you just said, you're saying that the receiving center will not take 5150s?
Yeah. It's not a
It's not a
LPS
LPS
designated facility.
Could it be upgraded to that at a different point?
At some point, it depends on the layout of the building, and certainly having an LPS designated facility is something that we are looking at separately, because especially with SB 43 coming down the pipe, we're gonna need, if SB 43 was in effect today, I suspect that we would have a lot of folks sitting in the emergency department with nowhere to go. And so we know that having LPS designated facilities is an upcoming need for us.
It's because just anecdotally, other counties have something called a crisis stabilization
Yes,
unit,
yes,
which
yes,
is a dedicated psych ER
Mm-hmm.
and has more providers available within the facility than an ER does. So in a crisis stabilization unit, they have social workers, a therapist, and a psychiatrist all doing the evaluation on the person brought into the hold. So there's a lot of different providers doing the evaluation rather than one person who may or may not be really kind of making.
But isn't Davis doing that? Isn't Sutter doing that right now? I was really impressed. A couple of meetings ago, we had that CIT presentation.
Yeah, it's just not a CSU. They don't have a CSU. So
Well, no, but I just want to say real fast, that I was really impressed with the CIT presentation several meetings ago. Because now, I mean, I don't like to say this, but I guess I'm really old, because I remember sometimes you had to lie to get into a mental hospital to get a 5150. Now you go to the ER at Sutter Davis, and within hours, they already got you going on good things, and you don't even need to be 5150. I totally agree with what you're saying, Kimberly, about services. I thought Sutter was doing that to a certain degree, though.
they don't have a CSU here. So there is, Prop 1 bond funding, facility funding, it has funding available for certain types of facilities. CSUs are one of them. Psychiatric health facilities are another. So we are having conversations with some of our partners and within the county around what are the facility types that we need in YOLO. CSU is certainly one of them. They have very different layout, licensing requirements, staffing requirements. And so while I certainly think we need one, this first sort of pilot wasn't the right sort of place to pilot a CSU. We really need partnership with our hospital systems, I think, in order to stand up a CSU. So
I do think though, real fast,
Yeah.
the CIT, especially in the ER room, I know at least Davis has improved greatly. I'm sorry if I'm like totally off track of what you guys are saying.
no, it's really good feedback, Brad. Thank you.
It's improved so much, I can't tell you. I mean, because it was like, before it was like a stop, start, line to get in, but then you have to be there for 3 days. And now it's, I mean, people can get help, seriously help real fast and not have to even be 5150.
The services offered in the ED for mental health are very different than what's offered in a crisis stabilization unit for mental health, because a crisis stabilization unit is a dedicated mental health psych ER versus like the ER, like the mental health aspect is kind of just an add-on. So they have a social worker that specializes in mental health, but it's not dedicated to that. So then often the Sutter Davis or the Woodley ER sometimes won't have a specialized psychiatrist on staff, so it's a social worker writing cold.
If I could piggyback on that, I actually moonlight in the crisis stabilization unit in Mercy San Juan. So you're right, they are two usually they are two physically separate entities. So the CSU in Mercy San Juan is across the road from the ED. So what happens is the ED refers patients to us, we go to the patient and decide whether the patient is appropriate, because sometimes the patients are agitated or maybe there's a bit element of violence, then maybe we would say, hey, why don't you hold on for a little bit longer, or maybe refer them directly to a psychiatric inpatient unit like Woodlands, or sometimes when the patients are appropriate, we take them into CSU. So we don't actually take patients directly into CSU, they go to the ED, they're screened. And one of the more important things is that we need the patients to be medically stable, because sometimes they have medical conditions. That's number one. We can't take someone who has a medical condition who might, decompensate. Like we had a couple of patients with really high blood pressure, which was missed. Some patients, they had pancreatitis, we didn't know, and then when they were in CSU, that became obvious they had pancreatitis.
Then you're in hell.
Yeah, so it's medically clearance is number one. But yeah, CSU is a great idea. I think Colin and we were saying we need to get you to Mercy San Juan.
Yeah, to see the empath unit. Yeah, that's the empath unit.
Let's go, because they partnered very closely with Placer County doing this, and they did some really cool things.
Yeah.
So I would,
Yeah,
highly
Dr.
recommend
Dustin's gonna help me get a tour of it, so
I can help you too.
thank you. Thank you.
Okay, we're gonna move on to E, public guardian, Sue.
Oh, well, I mean, first of all, obviously, I'm really happy about the extra positions for public guardian. But I was kind of confused about that third position, because when Nolan spoke to the board, you know where I'm going with this. Okay, when Nolan spoke.
She'll explain it. She'll explain it.
Okay,
Yeah, okay, so, the third position. So when we originally provided data, right, around how understaffed and how the caseloads for the public guardian's office would work so quite high, the initial calculation showed that in order to be at the recommended caseload size of about 30 cases per conservatorship officer, we needed to add 3 conservatorship officers. And in the initial discussion, well, I won't say initial, but at the board meeting when the decision was made to add 2, there was some discussion about adding a third by one of our county supervisors. It was not necessarily supported across the board, and the discussion, I believe, don't direct quote me on this, but it was something like, I don't want it to be, like, they wanted it to be a unanimous agreement, and everyone was in agreement to add the 2 positions. So that's where we sort of started. But then there was very prompt follow-up discussions and conversations about, but what about this third position, and what about getting the public guardian's office staffed where it truly needs to be? And so I do want to just acknowledge Supervisor Provenza has been definitely a strong advocate for that, and I think his position was, and well taken, was we need to have the public guardian's office adequately staffed now before SB 43 goes into effect, because if we have an opportunity to go to the state and say, this is an unfunded mandate, this is how much our caseloads have increased because of SB 43, and here's how understaffed we are. If we're already going into that understaffed, then we won't have a leg to stand on to say that there's an unfunded mandate and there's an implication for the public guardian's office around staffing. And so we went back to the drawing board, looked at more data. Our CAO's office had asked us to do some additional data outreach to other counties to get more specific data. We did all of that. A lot of these conversations were happening at the adult ad hoc committee. And so where Supervisor Provenza and Supervisor Villegas both chair. And ultimately, we came back to the board with a recommendation to add the third. And I shared this with Jonathan, I'll share this here too. We actually ended up funding it ourselves with salary savings from eliminating other positions in the agency. And so and it's not fair to say that we traded 8 positions for 1, because that's not accurate.
Okay.
But we did eliminate 8 positions from the agency, that the total general fund contribution for those positions equal what the cost is for 1 conservatorship officer. And so through our own cost savings, I think at that point, the board didn't really have any issue with the recommendation of the 3rd position, because there wasn't an additional general fund obligation then to add that 3rd position. We were able to add it through our own salary savings.
Okay, but see, that's where things get strange. I mean, for one thing, I just wanted to know where those positions came from, but for another thing, if it adds up to $130,000 and it's 8 positions, then we'd have to be paying them less than half the minimum
No,
wage.
so that's just the general fund contribution to those
Oh,
positions.
okay,
So
that
some
makes
of our
more sense.
Some of our positions are funded by multiple funding sources. Public guardian positions are all 100% general fund.
Okay.
So that's the difference, right? So while that one position is let's say $130,000 total, right? And it's all general fund for an I'm making this up. I don't know if we have an accountant position, but let's just say an accountant position, maybe 10% of their work is for general fund related work. And so maybe $10,000 of their salary is general fund. Does that make sense?
It does.
And so it was the total cost savings from all of the positions and the general fund contribution for any of those positions that had general fund associated with them. So we certainly don't pay anyone.
Right, I was trying to
Yeah.
yeah. So wait, so what did we actually lose then?
Yeah. So there were some vacant, some of the positions were vacant, but some were not. And so for the positions that were not vacant, maybe the role was eliminated, but they were moved to staying in their same class specification, but moved to another unit or another role in the agency. It was primarily positions in our administrative branch of the agency, which is fiscal, some other admin support functions. And so our admin staffing has grown over the years to support the infrastructure, and during, some tough budget times, I think there was some focus and direction on reducing our admin overhead. And so some of the positions ultimately were eliminated, unfortunately. They were all positions that we think added value to the agency.
Absolutely.
And they're very hard to let go. But there was other factors of why. It wasn't to get the public guardian position, so I want to be clear.
Oh,
Those positions were not eliminated to get the public guardian. That was happening separately from this. But one of the realizations from that process was those positions in total had about the same amount of county general fund associated with them that the public guardian position did. So,
okay, that makes a lot.
yeah, they were not eliminated to create that position.
Okay, F.
And just thank you all for your advocacy and support for the public guardian. They feel so supported. Lori feels incredibly heard and valued and supported, and you all played a huge part in that, so thank you.
Sorry, even though there was a decrease, there still was an increase, because there wasn't that deficit now in the general fund, right? So if it's say $10,000, that $10,000 you just repurposed.
Sure,
So still, I appreciate the fact that
absolutely.
they still added.
That they approved it,
They
yeah.
didn't say, no, we want that
Absolutely.
cut instead.
That's right.
So there still was an add.
Absolutely, and there are long-term financial obligations to having county staff, with pension obligations and other things. So certainly there is a cost associated with this. Yeah,
So
absolutely.
thank you for
noting
fighting for that.
Thank you,
because-
Frank.
Yeah. Thank you.
Okay, thank you. F.
Oh, I had said I didn't want to do it, I just wanted to thank you for it, so thank you for that.
Tony, thanks Tony and Mary,
Oh,
I think for that update, yeah.
Okay, we're gonna move on to, criminal justice report. Chris?
Okay, this is probably a good one. So we just talked with public guardian. Sometimes the jail will do a referral to the public guardian for conservatorship investigation. And we had two of those, went to court and they were conserved last week. So it's a long process when it starts, for a couple months. But we are taking some people out of the criminal justice system and treating them as a mental health issue. And so we had a couple of those last week. I noticed in the minutes, the Department of State Hospitals, the penalty was brought up. I was at a conference with Jonathan down south, mental health committee, and we were talking about different DSH diversion programs in different counties. I know we had a good one as far as the outcomes. Went and got the stats when I got back. And we have 10 people that have graduated from that program and only one failure, which is considerably higher than anyone else. So kudos to the HSA staff that are making that program work. We actually have 2 more graduations coming up on September 30th.
Chris, sorry, can I ask a clarifying question? So on the ones that were conserved, does that mean then instead of having to go through the program to have whatever criminal charges removed, that they go into the conservatorship so that is all closed out, or how does that
One
work?
person was incompetent to stand trial. And his case was dismissed in court that day.
Okay.
The other one, the case is on, I believe, next week. Cases, and those criminal cases may be closed out next week.
So they don't expect them, when they get conserved, then they become treated and then they have to go back through mental health?
We're not bringing
Okay.
one of them back.
Okay,
And that's probably because the person had spent so much time in custody, having previously been hospitalized,
Right.
that we were timing out anyway. So that can happen if someone's incompetent to stand trial and they're getting close to the amount of time we can hold them for that process, they get referred for conservatorship.
Right.
Instead of coming through that process, it came out of the jail.
oh, that's great, that's good you
Yeah.
guys are doing
So
that, because then that would free up 2 other spots from somebody
Well,
else.
it's a different program.
Different program, okay.
Yeah, unrelated programs, but it is happening out of the jail, but the WellPass staff is looking at it. Those referrals, not always successful. I've seen some that have failed, but some have gone through. We're also seeing some individuals in jail having involuntary medication order hearing. I had recently one of those, and so there's something that's new in the last year or two, or actually I think it's this year is the first one we saw. And so the jail is notifying county council, and the WellPass staff is making that recommendation. So that's a positive thing.
I'm so happy to hear that. That's
Yeah,
music
for
to
sure.
our ears, because so many
Absolutely.
times it's a catch and release, or,
Yeah.
you know, and they're sitting there and not being treated. So it's really, I mean, we're doing really great in Yolo County, obviously, if we're at that stage.
Well, it's a safety thing for those individuals, which is why they're doing it, but it is happening. I think it's important for this board to hear that.
Great work.
We talked about the nanny walk. The mental health court had due to staffing issues, referrals. They're back taking referrals again, so I think we're gonna have 2 graduation and transition out in the next couple of months. We're freeing up slots for that population.
What are the totals? There's a 30 max for each. What are we at?
We'll be down 25 for that population while staffing is being built. We want to make sure that each individual is getting the appropriate amount of services, and you can only have so many individuals per case manager they can provide services for safely.
What's the AIC at? You know,
The AIC has, I believe, 27 people in it at this point.
thanks. Ad hoc. Sue. Sarah, sorry.
That's wondering what I was supposed to know.
Sorry, Sarah.
I'm in this group and I'm curious too. so.
Yeah.
Oh, okay.
I'm not blaming it on you. I'm totally
So-
negligent.
Sarah.
Okay.
Sorry, Sarah.
I was gone for a lot of August, and I had a hard time connecting to Samantha and Carlene, and finally we get connected. We did a little meeting on our virtual, and they were gonna send out the forms for the documents, the questions for, we're focusing on Safe Harbor. We're gonna go visit them. And I'm in process of, I've emailed Amber Salazar, and I haven't heard back from her yet, so that's where we are right now. So we're still, it's in process.
When did you email her?
When? Yesterday.
I just want to make sure. that-
Well, because I didn't
Right on
connect to
Tuesday.
Samantha and Carlene till like
No,
Friday,
no, I
last
heard
Friday.
that there was some.
Yeah, and
That's fine.
I emailed to connect Amber and Sarah
Yeah.
on Tuesday, and Amber replied right away and
Yeah.
said, I'm looking forward to it. We'd
Good.
be happy to have the
So
local mental health board come and do a site visit. And so now they're just gonna coordinate directly. And in the meantime, Sam and I are just gonna do some very light edits of the site visit form, and then we'll get it back. And Amber would like to see that form, I think, before the
Yeah,
visit, so I told her
think
that we
that's
would send
good.
it to her. Yeah,
I think that's important.
Yeah.
And then we talked about maybe a visit, just of maybe 3 people or 4 people, small group visiting, not like everybody, too much. So
So who gets,
that's where we are. What?
so who gets to go?
I don't know.
I've already
Yeah,
been,
I'll
so
go.
I don't need to, but it's a small facility, so a small group would be appropriate.
Yeah.
I don't know.
Okay, great.
Speaking,
Yes.
can I make a comment real fast,
Sure.
John?
Yes.
I am now a worker for Safe Harbor.
Oh, you are?
Yeah, so there's two problems. Well, the first problem is I probably can't go on that ad hoc committee.
No.
The other thing is, I think I'm working on Wednesdays till 7 PM now.
Hmm.
So I don't know if you guys want to replace me.
what do you mean for the ad hoc, for the,
No, I mean like for the meeting in general, because I would have to miss the first hour, of every meeting.
Are they flexible on that? Or maybe you might, if you
Well,
would ask.
Well,
It's up to you.
I kind of can. The thing is that on Wednesdays around 6 PM, they're usually doing grocery shopping, which I would be supporting.
Right.
So, I don't know. Can I get back to you?
Yeah.
I wasn't even gonna say it publicly, but this came up,
Yeah.
and then this came up, so I just wanted to let you guys know.
Okay.
I just had a quick question. We'll still keep an active pulse on, like, just level setting the expectations of the site visit. And so just not that, I don't want the ad hoc committee just running rogue. I think there needs to be some oversight management so folks understand the intent and purpose and doesn't
Yeah.
spiral into something adversarial.
Yeah.
Yeah, we talked about that at the last meeting.
Yeah,
and we
Yeah.
talked about that with Sarah as well.
Yeah,
And so what we agreed on is that for any of our providers, that I would send the initial email. I'm gonna work on some canned language that I can reuse each time, that way I don't have to recreate the wheel each time. But to say, and I pulled it together for this one, but I'd like to refine it for future ones. Saying like, this is what the local mental health board is, this is what they do, this is the purpose of the site visit. And then providing them with a form so that they can, in full transparency, see kind of the checklist that they'd be going off of. And we did talk a lot about it not being punitive, not being some sort of evaluation, but really being more to educate on what services are available, to be able to hear more from the provider themselves about what's working, what isn't, and really having that help inform the larger mental health system, which is the charge of the local mental health board, right? So is having that sort of grasp and pulse on what the mental health service delivery system looks like in the county. We had a great conversation, and the first email, so the first provider was very well received. I mean, I don't know if it was just because I sent it, but it was very well received.
To do with it.
Yeah.
That's good.
Yeah, we talked about it being more of an information gathering kind of process, not like we're coming in here to look and see what you're doing right or wrong. No, that's not what we want.
That was my angle when I was a part of that committee, was making sure that there was a organized and formal approach to coming inside of someone's backyard and assessing their environment. Good job.
Yeah, thank you, Dean.
Yeah, no, thank you.
Good
I
point.
think even, yeah.
And I think having, go to, say, Forever Breeding North or Farmhouse, being able to see how they operate is very important for me in my job. But I think it'd be very important for everyone to have an opportunity to go to those locations and actually see what they are, what the services are, what they look like. So we have an understanding of what we're talking about.
What are the other thoughts in terms of like, other facilities?
Other
or,
facilities?
Like any, like what do you,
Well, we talked about what the wellness center. The farmhouse might be an option. I don't know what all is out there yet, so I'm still kind of new to this, so I don't know. what
You hear
would
about
be-
FSP and you hear about all these different terms. It would be nice to kind of visit different ones, right? Like what's a step down program? What is that? Is that like, what's a full service partnership? I mean, we kind of talk about it. We're learning the lingo, we're learning kind of bits and pieces of it, but are there multiple sites we can go to where we can learn that? I mean, and see it.
what about Carlene? What about 3B North?
Oh, you mean in Woodland
A visit,
at the hospital?
small group.
I know how those work. I've been in those before.
I'm not sure. I mean, it's certainly something we could explore. I'm just not sure that's a bit more difficult in terms of access, I think, and we don't have,
That's a locked unit, right?
yeah, and we don't have, a-
Yeah.
If I was them, I'd say no.
yeah.
We have talked
Yeah,
about.
we don't have any.
I wouldn't like it.
Yeah, I have no authority,
Right,
like, yeah, so
right.
it's like, we're, for some of these other programs, there are contracted provider, right?
Yeah.
That's not the, like, you
Yeah.
pay, like, for service, like, we're a payer, right, of service, but we don't hold a contract,
Right.
and we're not, they're under no obligation.
Well, they might,
They let the mental health court team on a tour a number of years ago.
3B North?
Yeah,
Well,
I was actually able to participate in that with Judge Guard when she was running it.
The
with
key is
different team
years
members
ago.
Years ago.
That's the
yes.
key right there.
Yeah, I mean, it's certainly something we can explore, right? And I'm happy to make some connections and have some discussions about it, but I just don't know how likely it is. I don't know, or I don't,
Yeah, I mean.
I just like that terminology of tour,
If
using
you
that word
guys
tour.
want that, I mean, I have pretty good relationships with people over there.
I would like to. I mean,
See if they do want to do that.
I don't know how you're gonna get around HIPAA.
I actually do weekends at Woodland and DHU 1 and 2. And Tandy, we've had this.
Yeah, Tandy.
yeah,
Tandy's
Tandy would
pretty
be,
good at that.
That's
We've
who I
had
would-
this
that's
discussion
who I
on
would
the
call.
yeah,
weekend.
Tandy would be the person I would.
During the
go.
week, sorry, not the weekend, and you can talk with her and she.
Yeah, that's who I would call.
I think one of the challenges that we have in this county is quality board and care, so maybe Pine Tree Gardens in Davis
Yeah, that would be
would
good
be a
too.
good place to visit.
What's it called again?
Pine
Pine
Tree
Tree
Gardens.
Gardens.
oh, yeah, okay.
That would be
There's
really
east and west, there's two.
good.
Which one
Okay,
would you suggest?
let's see.
Well, we're still in the ad hoc committees.
Uh-huh.
I noticed that the revised bylaws were passed last time.
You missed it after all that.
I know. My question is, on January 1st, we're gonna have to do that again. Are you keeping that committee intact or are you reappointing a new?
Yes, you jumped in, jumped out.
Okay, just wanted to know.
Yeah, so what he's talking about is because of Prop 1, which is effective January 1st, we have a number of changes we should make.
So I think we should probably have that draft in the last meeting before January, we can vote on it in January.
And let me throw something else out there just to think about for all of you, is changing the name of this board because of Prop 1.
I think Prop 1
I think we're
changes
ready.
it. by
Does it change it
statute.
I
automatically?
think we should
Yeah.
change
It
it.
becomes
We
the
should just do
local
it.
behavioral health.
Does it change it
board.
automatically?
Yes.
Okay,
Yeah, but
good, that
I
makes
think
it
we
easy.
should just change it
To
now.
require it, yeah.
Say we get it.
And
We could.
I mean,
it was on that topic with Prop 1, and I'm not sure it's the time to bring it up, but I do really think we need to get a presentation on addiction issues and treatment in the county. There's a opioid coalition that meets, and people might be interested in attending that. Attending one, I couldn't make the last one, I had a conflict. But we do need to get up to speed on drug treatment and addiction issues in the county. And I'm not sure, I know there's a presentation on one of the opioid coalition meetings, just kind of an overview. We might want to look at we're looking at a presentation scheduled up for January, February.
That's something you can help with?
Mhm.
Okay,
Yeah, that's right.
Yeah.
I know you guys had some priorities that you
Yeah, we still have to get to
identified
the
during the
children and
process.
mental health.
I know children is on
Yeah.
the list first, yeah, it keeps getting kicked out, I think,
Yeah.
because we have some, we've had some,
we have
like,
MHSA, we have children's, we have that.
yeah, but yeah, that's absolutely.
I know this is going backwards a tiny bit, but to the ad hoc committee, I would actually also say, Chris, that, going to Christie's son's, graduation was really profound. And yeah, going to, Safe Harbor or Pine Tree Gardens or Farmhouse is really good. I think it's a great experience for everybody here to see the success of individuals at that. I'm sorry, I don't remember all the technical terms, but Christie's son's graduation, it really opened my eyes to how much effort individuals are putting into to be successful in life. I would highly recommend one of the tours to be one of those graduations.
And it's an open courtroom, so we don't have to have a.
Exactly.
So people.
Exactly.
Yeah, we put out
welcome
two
to
dates.
attend.
Oh, did you?
Yeah, before you got here. Yeah, thank you, Brad.
Yeah, I mean, it was one of the best experiences, I thought.
Okay, any public comment? Public comment from our,
She left again. She's left a couple times and didn't come back, but she didn't come back this time.
okay, all right, okay, so, then we are adjourned. See you October 2nd, back to this space.
So Chris, when do you want to get started?
So I guess we'll be out too.
I just wanted
So-
to
so
thank you guys.
any
Thank the Public Guardian's Office for everything.
Like, once a month?
Well, I-
Maybe.